I know you quite well, but just so listeners who may not know you, could you just introduce yourself and your role in the Scottish PH service specifically?
Yep. So my name is Martin Johnson. I work with a fairly large team in the Scottish Pulmonary Vascular Unit. I've worked there since 2005, and I've been the director of the service now for the last just over 2 years.
And you're based in Glasgow, is that right? You're based in Glasgow?
That's right. Based at we're cut across a number of hospitals: the Golden Jubilee Hospital in Glasgow and the Queen Elizabeth Hospital in Glasgow. But we look after people from all over Scotland.
Mm-hmm. Okay, that's really good. So you've 15 years experience there then, Martin. So you're quite experienced, long in the tooth, as I think they say. A little bit, but
long in the tooth.
Yeah. I think it's just really helpful for people to have that confidence as well. That when we do these INFOCASTs, these are people who actually know what they're talking about on the ground and things. Mm-hmm. So being very specific to Scotland, and I know some of these questions will be generic as well. So, but just being very specific to the Scottish issue, how is the Scottish PH service managing the pandemic, the COVID-19, in things like appointments and seeing people and those sorts of things? How are you managing that on a day-to-day basis?
Well, we haven't gone into hibernation, but we have tried to cut down any activities that might put our patients at risk, and hopefully replace them with something which means they don't come to any harm from pulmonary hypertension. So, for example, outpatient appointments, we are still having appointments with patients, but they're all now via telephone rather than in person. Although if someone did want to come and see us, we wouldn't say no. We would still have the appointment if they desperately needed to come. So that's for the outpatient appointments. The inpatients, we have stopped doing investigations for new patients, which we used to do at the Golden Jubilee. We now stopped that. But what we're trying to do now is we're not stopping making decisions about patients referred to us. What we're doing is with the referral letter, with the local tests that have been done on the patients, we're still having an MDT. It tends to be a sort of video MDT now, and trying to make sensible decisions about those patients. And if they need to start treatment, then we'll start treatment. And if they can hang on, and it's not essential to start treatment, then we'll delay the investigations until we reopen again.
Right. Martin, you mentioned the phrase there, MDT. You have an MDT meeting. Could you just explain what an MDT is? Who's involved in that?
Well, an MDT is a multidisciplinary team meeting, and that involves usually several pulmonary hypertension consultants, radiologists, pulmonary hypertension nurses, and other experts like cardiologists and some of our junior doctors. And we use that to come to a balanced decision about diagnosis and about treatment plans in our patients.
Okay. So in a way, this is, and I know we're speaking in a couple of the INFOCASTs before, this is a new way of doing stuff, but possibly this might be a way of doing more of this type of thing in the future as well, because we certainly from managing people with pulmonary hypertension, I think we're all learning, aren't we, that it is possible sometimes to use telephone consultations and video consultations when it's appropriate. Obviously this is forced upon us, so there's a potential new way of doing some things in the future as well.
Yeah, I think so. We're clearly at the end of all this, where things are not going to go back to normal, or not probably for a number of years, and we're going to be reevaluating how we used to work before, and adapting it for the present, again to minimize risk to patients. And so, if we can find we can achieve sufficient with sort of teleconsultations, telephone or video consultations, then we're going to be using much more of those. I must admit there are some aspects of assessing how people are that we can't do via these consultations, such as, for example, doing things like 6-minute walk tests and examining the patients.
Yeah.
Those do need to be done in person. But blood tests could be done at a distance, and finding out about symptoms, functional class, quality of life scores, all of that can be done at a distance.
And done safely as well. And done safely.
Yeah, and done safely. Yeah. And done much more flexibly in terms of timing for the people involved. The other aspect of things is that I can sense that we're not going to. I don't think in 2 or 3 months' time we'll suddenly go back to what we were doing before. I think it will be a phased return rather than a sudden return.
In this sort of period of time as well, Martin, particularly on a number of things. One about the coronavirus itself, but also the coronavirus in the context of pulmonary hypertension. Where would you want to encourage people? Because there's lots of information out there, internet. Where would you encourage people to get the best information, the one that's going to be the most helpful?
I think probably 3 sources of information are I would point people to in the first instance. The UK government and the Scottish government have been very good at putting information on the web. So in Scotland, it's the NHS Inform website, which has got some good, sensible information, especially good for information on shielding, which is what we're asking our patients to do. There's the PHA website. You've been very good at keeping your information topical and up to date, and so I would certainly recommend that they look at the PHA UK website. And then lastly, I would say not a website, but our nurses have changed from working in clinics and doing ward rounds to largely manning the telephones. I would say don't hesitate to phone, because you're now much more likely to get a nurse and an answering machine, and they can direct you to, if you've got a particular question, they'll be able to direct you to the specific answer for that quite quickly, I would hope. And if necessary, get one of the medical team to talk to you.
Right, that's good. You mentioned in there, Martin, about one of the things you mentioned there was about shielding and this. Can you, from your perspective, again, people sort of sometimes think, well, what is all this about? What's the value? What's the benefit of this shielding? Why is it important?
So the aim of shielding was to make community-acquired infection of this virus as low as possible for anyone with serious health conditions, where if they got this viral infection, they might have a poor outcome. So shielding is people who've been asked to shield have been asked to for a period of 3 months to largely restrict themselves to their house and avoid contact with the community. And so that means things like not going to the shops, if possible, not having contact with other members in the community. I must admit, it's a very frightening kind of thing to ask people to do, because it's very isolating. But the people who come to our service have been seem to be taking it very seriously and appreciating that it is for a limited period of time, and that is the thing which is one of the things which hopefully keep them as safe as possible.
Absolutely, and it is about their safety, isn't it? Because I think sometimes and it must be really quite frightening, but it's not a punishment, or not. It's just to protect them, so we can get to the other side of this pandemic.
And when community levels of the virus fall, then hopefully shielding will be relaxed, and it will be much safer for them to go back to their normal life.
Yeah, yeah. On a very practical basis, and just from the Scottish experience, that the medicines that we use to treat pulmonary hypertension are very specific and often come from home care delivery things.
Mm-hmm.
Are there any sort of specific concerns, issues, or comments that you'd like to make about those? That are they still easy to get? Are any issues or concerns?
Yeah, we've been in when all this started a month or so back. We were in contact with Lloyd's Pharma, who do the deliveries in Scotland, and they at that point didn't foresee any issues with continuing deliveries, and our patients get all except the patients on Flolan get the drugs delivered every 3 months.
Right.
And from what I've been told, there have not been any difficulties in Lloyd's accessing the drugs. So no, it seems to have been quite straightforward. And now, as you know, it's common for patients who are shielding even to get their local drugs delivered by the pharmacist rather than going to the pharmacy to collect them. So it's becoming a much more accepted and widespread practice.
What about?
So, no, it's working well.
Yeah, no, that's good. That's reassuring. It's just that, again, I think you sometimes get these rumours about drug supplies and things like that. I think it's just keeping that context of the not to panic and certainly not to stockpile and sort of those sorts of things.
Yeah, I think so. Certainly, we've not had problems. And if problems were to develop, there are always solutions to this that we can instigate at short notice. So certainly, I wouldn't panic because I'm sure even if a shortage developed, we could institute a fix very quickly.
Good. What about sort of staying with the drugs sort of issue a little bit? Because some of these drugs you need fairly regular blood monitoring, whether the pH drugs or warfarin levels. What any specific advice there or reassurance to people?
Yeah, I mean the drug which particularly needs frequent monitoring is bosentan, and we do have a number of patients on this drug. The other endothelin receptor antagonist drugs, ambrisentan and macitentan, are felt to be a lot safer, and you can leave drug monitoring for those or blood monitoring for those to longer intervals. What we've suggested, we've sent a letter out to all the Scottish patients, and what we have suggested is that patients on these drugs only need any blood test doing once every 3 months. So hopefully that will be just before and just after the shielding period ends. The other drug which requires blood tests is warfarin.
Yes.
And what we've done with a number of patients now is switch them. These are patients with pulmonary arterial hypertension, so usually idiopathic pulmonary arterial hypertension. What we've been doing with those patients is switching them to the newer blood thinning drugs which don't need monitoring. And we've done that with a few patients now with no issues. And we are going to roll that out for all the patients certainly with idiopathic pulmonary arterial hypertension, so that they don't need to go to anticoagulant clinics or their GPs, or they don't need medical staff coming in unnecessarily to check their tests. So that's going to roll out over the next week or two as well.
Oh, that's good. Well, one of the things, Martin, we talked about when we spoke to some of your colleagues on the other side of the border in England, etc., is the strength of the pH service in the UK and this sort of collaborative work, and particularly at this time. It's not unusual just at this time, but it is a very strong collaborative group, isn't it? The UK service.
Yeah. Yeah, and even more so at this point, because our previous contacts used to be roughly every 3 months or so via either in a person-to-person meeting or in a video call. But since this pandemic has been upon us, we've been having a once weekly video call on a Tuesday morning, basically to share our experiences at this time, to discuss problems that we're experiencing, and and amongst us all decide on the best way forward to help manage our services and help the people who are attending them. And that's been very useful in sharing ideas, and we certainly plan to continue that, and may well be one of the things which continues. This more frequent contact could well be one of the things that continues after this pandemic is over. But certainly, we're a very cohesive collection of units, and largely we want to give the best care and uniform care across the country.
Yeah, with the best evidence, and some of that evidence it comes by experts sharing their experiences and things. So can we just talk a couple of things very specific about the COVID-19, Martin? That I think there's two questions. The first one is that if somebody became unwell, and we'll talk in the context of the Scottish patients, but then there's a generic here. If someone becomes unwell with the symptoms of COVID, and they're asked to look after themselves at home because they're not too unwell, how would you expect, what advice would you be giving there? What does it mean to stay at home? What things would you be asking them to look for, do, etc.?
Okay. Well, it's the virus is the symptoms people get do vary clearly vary between individuals, but there seems to be a sort of a reasonably definite pattern occurring with this infection. The first thing to say is don't panic, because most people who have this infection are back to normal within the space of 2 or 3 weeks. The first phase of the illness tends to be a sort of flu-like illness for about 5 days or so, and for most people that's all they have.
Well, what does that mean, Marty? Because some people want to have had flu. What does flu? I don't know if you've had it.
Flu is sorry, Ian. So flu is symptoms of fever, muscle aches, and generally feeling under the weather. The kind of symptoms that if you take paracetamol for it tends to have a good effect at improving your symptoms. Also important at that point in the illness, because you've got a temperature, don't stint on fluid intake. You've got to keep your fluid levels up. Don't get dehydrated. Also important if to keep taking your normal medications. After that is the sort of phase where people tend to develop a cough, and now not everyone gets that, but and again it tends to be a few days, and then it will resolve. It's if people start to get the cough doesn't get better, but moves into shortness of breath, that I think people should definitely be seeking more expert advice, because the sort of 5 days or more into symptoms that's the point. If people are going to get any kind of pneumonia with this problem, then that's when it will happen. So if the fever, muscle aches, cough is developing into shortness of breath, they need to seek help. Right. I would say. And a small proportion of people who have this virus get a pneumonia-like illness, and again, most people recover, but that's the part of the illness which needs fairly careful monitoring, I think. Okay,
I mean that's a really important message there as well, Martin, isn't it? Because I think sometimes with the news and it's not the news' fault, it's where it comes that everybody that gets COVID is going to be really sort of suffer and things like that. And the reality is that's not the case. So it's not the case. Not to panic. It's about sort of managing this thing. But let's say that somebody did become unwell with pulmonary hypertension, and one of your patients in the Glasgow Centre. What would you expect? Who would you expect them to call? What would they do? Would they call yourselves or something more local?
Well, I would say there's a number of different routes they could take, but I would say if anyone thinks that they've developed this illness, we'd like to know about it. So if they could phone us, as I said, there'll be a nurse by the phone just to let us know they're unwell, and if they wanted to continue to give us progress reports, and if they start to get shortness of breath and they tell us that they're starting to get short of breath, then we would be advising them to be getting themselves assessed. Now, that will usually be local to them, so it will be NHS 111. Hopefully not a 999 ambulance. Hopefully, we don't really want them to get so unwell that they need to get rushed to hospital.
Yeah.
Really, if they're getting breathless, and NHS 111 get assessed. I think each different parts of Scotland are tackling this in a different way, but we have community assessment centres, which is basically the GP services divided into two. One part of it's seeing non-COVID related problems. The other part of it is these community assessment centres, which are assessing people for possible COVID illness. And someone there would assess them and advise them whether or not they would need to go to a hospital for further assessment.
That's good.
And if they then, from the community assessment centre, if they do need to go to the hospital for assessment, not to be frightened. It's not where most of the people who go into hospital with this problem, if they get admitted, they're there for a period of time, which is a week or so. But most of the people survive that if they have a pneumonia and need to be admitted.
I mean, I think that's very helpful, Martin. I think one of the other things that we've talked a couple of times on these INFOCasts about in this scenario is it's really good if people can be prepared just in case, or make sure you know where your clinic letters are, where you've got a list of the drugs that you're on, just in case you need to speak to somebody more local. So, I mean, it's a good thing that we should all do. We know that, but particularly at this time, rather than things, oh gosh, I'm really unwell, and my husband's not well, etc. Where's the letters? To have everything to hand, so if you need to speak to healthcare professionals, you've got that information there ready. Being proactive and being part of that sort of care.
Yeah, that's very important.
Yeah. Just to come to a close then, Martin, it's been really good to speak to you. And what would you, this is sort of almost like the final message, what's your take-home message at this time for generally all people at this time with the COVID virus, but particularly the people with PH and those who live in Scotland? What would your sort of key message or messages be, do you think, Martin?
Well, I think my message would be to say that, I think 6 weeks ago we were very worried about this pandemic, and we're still worried. We're not being complacent, but I'm glad to say that the impact on patients with pulmonary hypertension in Scotland so far has been very small, which is good news. I'm sure a good deal of that is to do with shielding.
Yes. Yeah.
And certainly the numbers that we are seeing of people with this condition in Scotland are now falling. So hopefully the risk to all our patients is now diminishing, and it won't be too long before the shielding advice can be lifted, and we can get things back to normal. It's still not. I don't think we're talking about being weeks away. We're probably talking about being a month or so away. Yeah. But so far, I would say that patients with pulmonary hypertension in Scotland have done well, and I'm hoping that that will continue until we can get the service back in order and we can start seeing you in person again.
Excellent. Well, thank you very much, Martin, and our best wishes to everybody in Scotland and the Scottish PH service. And we may come back to you in the future, Martin, to sort of revisit some of these things. But there are really clear messages there. And while your key message is we're not underplaying this, but now we're into this condition, and I think because of the good work a lot of people have been putting into this, is that it's being managed. It is a serious situation, but we're managing this well, and we're learning a lot as well. So, as I say, once again, Martin, thank you very much, and we'll speak to you soon.